So good evening, good morning, good afternoon to everybody around the world. We are now with our second English webinar with Professor and friend Amshul Sama. As you all know, Professor Sama is one of the biggest sinus surgeon. For me, is one of the most elegant sinus surgery in the world, specifically in frontal sinus surgeon in the world. So I'm very happy he accepted this invitation and he is with us now to share challenging cases of frontal sinusitis. Professor Sama is now a consultant at Nottingham Hospital. You can see his background, his very wide background regarding rhinology, facial plastic, and even medicine, everything. So, Professor Sama, I will use this opportunity to announce your course. Hopefully, we will not have coronavirus, and we can go to your course. I took the liberty to announce it because I think this is. I couldn't have time to go, but I'm only here good. I don't know how to say it. Sorry.
We shall have you the next one, Cristobal, definitely.
Oh, thank you. Good things about your course. So I won't delay more. So I will give you the screen for you to delight us with your talk. So
I will just like to say, Cristobal, thank you very much for this amazing opportunity. I really appreciate this opportunity to share thoughts. And the beauty of this platform is that it allows you to share people from all over the world in a very short time period without having to really worry about travel. And also, I think it has put together people that have previously not had the opportunity to meet face-to-face that much. So I must confess, I've made more friends during this period than I have in the past, although I still miss my good friends because meeting them face-to-face, hugging, and it's a different thing. Spending a bit of time together face-to-face.
Yeah, exactly. But I think that the mixture of both will be the perfect.
It would be perfect.
As in everything. So I will share your screen and you can start whenever you want.
Let me know when my screen is up.
It's already up.
Okay. Oh, thank you very much. Yeah. So thank you. Just want to Nottingham, which is where I'm based, which is about 100 miles north of London. Easiest way to remember Nottingham is Robin Hood. So this is Robin Hood country. This is where Robin Hood came from. And the castle that you often see in the films and history is still here. And so is the legend of Robin Hood still lives with us. So if you ever get the opportunity, it would be very nice to have you in Nottingham. So my talk is really about frontal sinus surgery, something I'm very passionate about. But I think what I'm going to try and do today is to give you my approach to this condition, how I look at it, what do I look at to make decisions, and some surgical tips from some videotapes and what are the key things that I feel are important. So it's a mixed bag of disease. When you look at frontal sinus, it's all not one condition. There is lots of different variations. Some conditions could be quite easy to deal with. Some conditions are a little bit more challenging and demanding. And like cats, which are of different types, but the same family, they can all be very different in their ferocity. And one thing I've learned over the 20 years is how to identify the one that is going to bite you back or create trouble. And hopefully I will share with you some of my ideas of how and what I feel are most important. Traditionally, we are told that we approach frontal sinus surgery in a systematic manner. And this is what I call my traffic lights, the red, amber or orange and green. And we would traditionally say that the endoscopic conservative procedures are the predominant ones, and you have a stepwise approach that you would start with ethmoidectomy, Draf 1, and then work your way to Draf 3. Now, that may be good as a starting point, but it is not uncommon that you may get a problem up front that you have to jump straight to the third step, or sometimes even to the fifth step. So although this is useful in understanding that maybe our approach should be more conservative than obliterative, it doesn't help you making the decision when you have a patient or a condition in front of you. So I'm going to share some of my thoughts on that. In a very small nutshell, this kind of is where my philosophy comes from. So these are the things that I consider when I'm looking at my approach to frontal sinus problem. And there are four aspects to it. Each one has its impact. So pathology, what are you dealing with? Are you dealing with benign inflammatory disease? You're dealing with aggressive inflammatory disease, such as in Samter's triad? Or are you dealing with benign neoplastic pathology like inverted papilloma, or invasive neopathology in that, so a cancerous disease? The second aspect of dealing with this is the anatomy, because from the nose endonasally, we have a very limited window that we can enter into the sinus cavity with. And that restriction restricts or guides what kind of procedures we can do. That two together will determine your approach. And the approach is either endoscopic, transfacial, or even osteoplastic flap. So those are all ways of getting to the problem. They are not an operation. It is a way of getting to the problem. It's the same as in ear surgery, you may want to do a front approach or you want to do a back approach. It's the same thing. And then the operation is, what are you going to do with the natural drainage pathway, and what are you going to do with the pathology is the operation that you're going to undertake. So this is how I make my decision making. Transfacial approaches, in my opinion, have very limited need nowadays. Most of the time, with the exception of a mini trephine or a trephine technique, where you may do a lateral trephine to get a bimodal access. Most of the traditional transfacial techniques we know are fraught, because you will compromise by drilling away the most important anatomical restriction of keeping the frontal sinus open is the lateral wall. So transfacial is usually, but however, I still do use the osteoplastic flap. I think it's a very good technique for very specific pathology, but I'm going to concentrate predominantly today on talking about endoscopic approaches, the endonasal approaches. Now, although we say it's an endoscopic and endonasal approach, I still look at the endonasal approach in three corridors. We have learned that from skull-base surgery. We have different corridors which we can access different pathology or different parts of the anatomy, and we have a similar possibility with the frontal sinus. Now, the frontal sinus and the sphenoid sinus both are midline sinuses, unlike the maxillary and the ethmoid, where one complex is entirely separated from the other. The midline sinuses tends to have three approaches to them. You can have a straight transnasal approach, say for the sphenoid, a transnasal approach to the natural ostium. You can have a transethmoidal approach, or you can have a transseptal approach, which is the often approach we would take for performing any pituitary or hypophyseectomy procedure. Similarly, for the frontal sinus, we have three approaches. We have the traditional transethmoidal corridor. You have the ethmoidal corridor, you go through a middle meatal antrostomy, anti-ethmoidectomy into the frontal sinus. You alternatively also have a transnasal corridor. In that, you can enter the frontal sinus completely ignoring the ethmoidal complex through the nasal cavity, and then address the frontal sinus or the ethmoidal disease afterwards. And lastly, you can also potentially have a transseptal corridor. You can follow the septum into the floor of the frontal sinus and then be able to access both sides depending on what you're dealing with. Transeptal corridor is not one that's often used, but it's there and it can be used on certain occasions. So remember, there are 3 different ways of getting to the frontal sinus, even with the endoscope or the endonasal approach. So after we get there, what we do with the natural opening of the frontal sinus is where the Draf classification comes in. And now we're all familiar with 1A, 1B, 1C, 3, and this is essentially defining how much of the floor of the frontal sinus we will remove. I'm sure you're all fairly aware of this classification, but I would just simply reiterate. Type 1 obviously is simply opening up the ethmoidal complex such that the natural ostium is open into the ethmoidal complex without instrumenting the natural ostium. Type 2A is where you would enlarge that natural ostium from the lamina papracia all the way to the middle turbinate. So you have enlarged the ostium into the whole of the ethmoidal complex. 2B, where you enlarge it all the way to the septum, and 3 is when you take it right across to the other side, but also take the intersinus septum and the nasal septum down to create a singular bilateral opening for the frontal sinus. These are the factors which I take into consideration when I'm dealing with my decision making. So remember, I said anatomy plus pathology, or pathology plus anatomy, equals to your approach and the operation. So these are the factors I would like to go through. I'm not going to go through all the pathologies, but I'm definitely going to visit some of the anatomical factors. Position of the pathology in the frontal sinus, very key thing, and we will revisit that because there are some misunderstandings and concepts. The dimensions of the door that allows us to enter from the nose into the sinus, which is the anteroposterior, from the cribriform plate to the anterior wall, and lateral medium from the lamina to the lamina. Certain types of cell types which obstruct the airway. Pathology, as I mentioned, whether it's a benign pathology, aggressive pathology, will determine how much of an antrostomy you need to make. For benign pathology, you may just need type 1 or 2A. For more aggressive pathology like Samter's triad or certain type of tumors, you may need a 2B or a 3. One of the most important, when you start doing this quite a bit and you do a lot of revision surgery, one of your biggest enemy is this neosteogenesis or new bone formation or osteitis. Your decision whether this is the primary surgery or revision surgery affects your decision making, and whether there's an acute inflammatory disease where you need to be conservative. So I've kind of used this philosophy, and we published a paper on looking at this. So if you want to read more into these different segments, it is available on this, and I'm quite happy to share that with you if you require. But it kind of used these factors to make a decision of what kind of an antrostomy is likely to be most appropriate. So for instance, if you've got a mucosal that is quite intermediate, but you've got 50% osteoneogenesis, then it is likely that you will need a type 3 or osteoplastic flap approach for that. So this is just a guideline, but it kind of is a way of thinking how to work your way through frontal sinus surgery. Position in the frontal sinus. Additionally, if you look at the literature, there is a fair amount of confusion on what is considered medial, what is considered lateral. So just to define, for my purposes, I find the medial most presentation of the pathology in a parasagittal plane. So parasagittal plane being parallel to the septum. And if we go in a parasagittal plane, the medial most aspect of that pathology is what determines its position. So if it is medial to the lamina papracia, then I would call that pathology presenting medially. If it is lateral to a third of the orbital rim, then I would call that a lateral pathology. And if it's in between, it's an intermediate pathology. And just as an example, here are 3 examples of what I mean. So here, although on the left-hand side you will say, well, actually the dehiscence and the orbital involvement is quite lateral. But the medial most presentation of that pathology is medial to the lamina pepracia. So actually dealing with this condition is not difficult, provided you access the medial aspect, and the rest of it will then implode spontaneously. Here, this is a mucosal subsequent to a cranial surgery, and you can see that there is a lateral supraorbital mucosal here, but the mucosal's most medial presentation remains lateral to the lamina pepracia. So this is a little bit more challenging because your corridor is a bit narrow and further around. And lastly, here, where you've got somebody who's got a completely isolated disease lateral to a third of the orbital rim, would be a lateral pathology. This pathology's most medial presentation is here. It's not there because you've got pathological process in between. So here, obviously, one of the concerns you'll have is you'll have exposed dura as you're trying to access that pathology from the previous surgery. As an example, if you look at this, initially you'll think that's lateral, but as we come, you can see that this presentation is medial. So that to me is medial. What do I mean by limited anteroposterior lateral medial dimensions? So examples here of people who've had surgery, these are obviously revision surgery, and this is one of the reasons why I am very cautious about transfacial approaches, is that when you do a transfacial approach, to approach the pathology, you will drill the key factor that keeps that door open. And once you've drilled that away, the problem becomes the soft tissue will now implode and further narrow your drainage pathway. So here you can see an example where on the other side, you've got a fairly large lateral to medial, frontal to LP and AP dimension. Whereas on this side, you can see that you have very limited dimensions to the natural ostium or the drainage pathway for the frontal sinus. This is a limited, restricted position and requires a more aggressive approach. Also, at the same time, I'm not an advocate for stents because I believe they cause, especially rigid ones and long-term, because they will cause osteitis. Everything closes around them and they never really function adequately. The second important thing that you will come across, and this is your biggest enemy, is this condition of neo-osteogenesis. In other words, of new bone formation. And here you can see where you've got a patient with a very lateral pathology because the medial most presentation is more than a third of the orbital rim. But between you and the pathology, there is a lot of new bone that has formed with cystic and inflamed osteotic bone. And when you've got this kind of structure obstructing your way between the nasal cavity and your pathology, then you have a lot of issues and you have to think out of the box and be a bit more aggressive and be a lot more thoughtful about how you're going to manage the problem. So I would say that any condition where more than 50% of the pathology of the osteitis closes up this distance, you will have a troublesome, difficult position. This is sometimes can be quite a challenge, this isolated pathology that can occur in the supraorbital cells. So here, a somewhat complex patient who's had previous surgery, obviously, he's got almost complete obliteration of the opposite side due to osteoneogenesis, but he keeps presenting with recurrent bouts of orbital cellulitis and proptosis because he's got this mucosal. At first sight, you may think that is a frontal mucosal, but as you look at the sagittal cuts, you can see the frontal sinuses here. This is actually a supraorbital mucosal, which independently would drain into the ethmoidal complex. And these can be very difficult sometimes to deal when you've got this degree of osteogenesis And then you have a very, very narrow corridor between the orbit and then the cranial cavity. And there are more innovative ways now that you can do orbital repositioning methods of getting to this, which are, I think, in amazingly great ways of approaching these problems, whereby you take the lamina down, you use a flange to protect the periorbita, and you deal with the disease and allow it then to regress. So, but this in isolation can be quite a significant problem to deal with. I'm sure you're all aware of the different types of frontoethmoidal cells, and these have been reclassified. The true frontoethmoidal cells are obviously the ones that invade into the frontal sinus. The ones that are below the oblique are truly just ethmoidal cells that are the type 1 and type 2 Kuhn cells that are obstructing the frontal drainage pathway. But the true frontoethmoidal cell is the one that grows from the ethmoidal complex into the frontal sinus. And these are the type 3 and the type 4 frontoethmoidal cells. And these cells will sometimes help, and most of the time will actually make life more difficult to deal with. They help because they widen the AP dimension quite often, and usually these occur when the frontal sinus is fairly widely ventilated. So the whole ethmoidal complex has universally grown into the into the frontal bone. But if you're not aware of them and you don't look out for them, it is very easy to go and drain the cell, but leave the frontal sinus undrained. So it's important to recognize them and address them at the same time. So this is my workhorse, type 1, 2A frontal sinus surgery. This is what I would do most of the time, and I would prefer to do most of the time. Unfortunately, with revision surgery, when you have lots of revision procedures, then 2B and 3 are very important ways of dealing with the problem. But I think if we could all learn to do this procedure well, we will serve our population, a majority of our population, well, because most of the people don't need drills in their frontal sinus. They need proper procedures done properly to actually get good long-term outcomes. So what I'm going to do is just share with you a short video with some points of how I approach this problem. And it may be some of these points you could take with you in your work. So what is a 1 and 2A? 1, as I mentioned before, you simply clear up the pathway to make sure the natural ostium is open into the ethmoidal complex without instrumenting or enlarging it. And 2A is where you would enlarge the all the way from the lamina to the middle turbinate. Now, these are always done through a transethmoidal approach corridor. You won't approach this through a transnasal or a midline approach, because they are really only good for 2B and 3, because this is always the transethmoidal corridor. One key thing I would like to mention is that there is an old saying that ethmoidectomy is enough to deal with the frontal sinus, and I strongly want to clear and emphasize that this is not the case. It's a question of what do you mean by ethmoidectomy. The traditional ethmoidectomy starts with an uncinectomy, never addresses the agonase or any of the type 1 or 2 frontoethmoidal cells, will go straight to the bulla and then take the basal lamella down and do a posterior ethmoidectomy. And if you look at that corridor on the sagittal plane, you will see that you have missed out most, if not all, of the pathology that affects the frontal sinus and its drainage pathway into the frontal sinus. And you'll also recognize that the anti-ethmoidal artery usually doesn't come into your field when you do this. Now, I appreciate that some people would do this and then come back to front and clear this up. And I have no issues with that at all. Which way you do it, whether you do front to back or back to front, is entirely your preference, provided you address these cell types here, the suprabulla cell, the anterior frontoethmoidal cells, and the agar. Unless you address this, you will never get adequate drainage for it. And here are very common examples of revision cases where you can see that corridor has been used and the anterior chamber has been left completely unaddressed. And you can see that the roof of the agar there, the roof of the bulla and the suprabulla cell has left intact. Now that frontal sinus will never drain as much as this ethmoidal complex will work. And similarly here, and here are examples where the bulla, the agar, and the ethmoidal cells have not been adequately addressed, and you will never get a draining frontal sinus. So I think ethmoidectomy is only enough if you address the anterior ethmoidal complex completely. And therewith lies, how do you approach your surgery? So I approach my surgery front to back, and I take this from the embryological learning. The lateral wall in the ethmoidal complex develops from ethmoturbinates 1 to 6, and these develop into vertical doors that you walk through into a room, which you clean before you walk through the other door. So I call this technique walking through doors. Essentially, your first door is the agonese and the uncinate process. And the key thing to remember with the agonese uncinate process is that they actually form from the same ethmoturbinate as the agonese. So if you truly deal with the uncinate, if you only do an uncinectomy, it's a partial removal of that first ethmoturbinate. Unless you address the agar at the same time as the uncinate, you haven't opened the first door. Your second door with the bulla ethmoidalis, third being the middle turbinate basal lamella, the fourth being the basal lamella of the superior or supreme turbinate, and the last being the face of the sphenoid. Each one of this walks into a room, and you clean that room before you walk into the next one. So the first door, example here, this is the uncinate, and you see how the uncinate forms the posteromedial wall of the agar. So if you simply remove the uncinate but not the agar, then you haven't really adequately removed that door. So my uncinectomy always addresses the agar in the same step. Only then can you get access to the frontoethmoidal cells and the suprabulla cells to be able to address the drainage of the frontal sinus. Ideally, you want to open the first door and clean the first room. Now, if you clean the first room of all the contents, you will get your antrostomy into the maxillary sinus and an opening into the frontal sinus simultaneously. Once you've got that, you have cleaned that first door. So let me just show you some another point. When you're doing a bulla intact approach, when you're doing this, is always keep the face of the bulla intact. And here you can see multiple different types of anatomy. None of these I would operate on because there's no pathology, but it is very easier to show anatomy when you haven't got pathology. And you can see if you follow the face of the bulla, it will take you to the frontal recess and the drainage pathway. If you follow the face of the bulla, it takes you to the drainage pathway, irrespective of the kind of pneumatization you have. So let's just share with you how I do my Draf 1 and 2A procedure. I prefer to do a retrograde uncinectomy, and your uncinectomy starts at the level of the floor of the bulla, coming back to front till that allows you, and then you can sublux the uncinate or component. How you remove that? This is an old one, so I used to use a avulsion. Key things: don't pull towards you, you pull back and forward. And you use your shaver really like a rubber. You're gently using it to just remove some of the excessive mucosa. You're really not rubbing against the bone for this. And you can see immediately that the uncinate forms, that's the floor of the agar, because the uncinate forms the posteromedial wall of it. So continuing with the antrostomy, I would then fillet the rest of the uncinate process out, and then you will find that the natural maxillary antrostomy will open without actually having a raw surface. So then you don't really have to. So you can see I haven't really opened. The natural ostium has got mucosa lining all the way circumferentially with mucus disease inside, and that means I can leave that antrostomy open. I'm sure it won't drain. Here I'm taking the face of the agar out, which forms, and be wary of pulling the mucosa off. So take through cuts, and then you take the back wall of the agar off, always keeping the bulla in your vision. That's your back wall. Now, this is a technique which I call a pateplasty. You've heard of balloon sinuplasty. This is a pateplasty, where you use a pate on the face of the bulla and you gently roll it up towards the frontal recess, never pushing your probe above your vision. So your pate remains, your probe remains within the vision. The pate will find its own way. So using the face of the bulla to find your way towards the frontal recess. And often this bit is quite astonishing for people as to, or my trainees, when they see how many different pates I get into the frontal sinus. You can get 5, sometimes 6 pates into that area. And the idea is to use the decongestion from the pate and also the compression from the pate to allow you to open up the natural drainage pathway. And as you pull these out, you will see how the natural opening will tend to fall into your lap without any significant mucosal damage. So you follow the face of the bulla, and the bulla takes you straight to the natural ostium. You can see the skull base is at that level, the natural ostium, and now you can start taking the bulla down in view of the fact that you know where the skull base starts, because you can see the back wall of the frontal sinus in your view all the time. So always keeping landmarks in front. I always use a 0 degree as a rule when I'm doing this procedure, and always use the shaver as a rubber, not to really rub against the bone. So sometimes, however, you have to do more radical procedures. So the 2B and 3 are then quite important operations. Now, although the 3 is the commonest procedure that people want to hear about, I think 2B is a very important operation and will probably serve a large proportion of the population where we often will go for a 3 procedure. A lot of people will say, well, a 2B doesn't really, can be prone to narrowing, but we've done some work on this, and I'll show you, share with you. This is, if you do the procedure properly using septal terminal flaps, our revision rate in a combined series between myself and Philippe from Paris is 4% with Draf 2B. It doesn't matter whether you're using inflammatory or neoplastic pathology. And even though the 50% of these cases were almost revision cases, we can actually, if you use appropriate mucosal preservation and mucosal flaps where you're using a drill, you can definitely have very low stenosis rates. So how do I do my 2B, and what's the difference? So this is a case of a mucosal with a Draf 2B with some pertinent points. Now here, I tend to use a transnasal corridor. And I'll show you a little bit more on that later on. But the transnasal corridor, this is the nasal cavity with the middle turbinate being above, and I'm making a curved incision over the roof of the nasal cavity and a linear incisions towards where the septal branch of the anti-ethmoidal artery would penetrate into the nasal cavity. This is actually not the mucosal, it's just the mucus from the agar cell, because as you can see, the agar would be where the middle turbinate attaches laterally. Now, the key aspect here is to get into the subperiosteal plane. You really want to be dissecting on the bone all the way around rather than tunneling. So you can see there, you can just about start seeing the subperiosteal plane. And it's important spending a bit of time getting into that plane, and you move the mucosa back, and this mucosa you're now going to use to cover up any drilled bone that you will create to for your natural ontrostomy. And as you push this back, you want to look for this landmark. You will see a vessel in this roof of the nasal cavity, and you can see grooves here. These are vessels. Grooves are made by arteries, not by nerves, though always there will be some olfactory filia or the anterior ethmoidal nerve associated with this. Once you found that major landmark, you can then start addressing the pathology, because you know that's where the skull base is. Any dissection in front of that is safe. So I'll just move this forward a bit more. So we open into the true opening by going, so that landmark is where the first penetration of the skull base is. If you keep that in your vision all the time, you know that if you go any deeper than that in your dissection, you potentially can go in skull base. Once you found that and the posterior wall of the skull of the frontal sinus in your view, you can actually quite easily deal with the rest without needing, in my opinion, navigation here. So I use all the mucosa I can, and you can see here I'm using the superior part of the mucosa to cover up the edge. Now that's the orbit, which is dehiscent on the lateral side, and the drilling. The drilling needs to be conservative but decisive. So you need to be going medial to lateral so that you're creating a ball. You don't want to be tunneling, you want to be creating a ball, and you don't want to be sacrificing excessive degree of mucosa beyond what the flaps you have raised, because mucosa is what's going to preserve it. Now, although that antrostomy you may think is enough, but to actually achieve a proper 2B, you need to drill away all of this bone, which is the floor of the frontal sinus. And that is when you will really get a proper Draf 2B, rather than just having an opening going from the lamina to here. You really need to drill the floor of the frontal sinus off so that you can see the anterior wall of the frontal sinus with a 0-degree scope. Whilst you've got that landmark in your vision and you've got the back wall of the frontal sinus in your vision, you know you can drill away as you like. Now we bring those mucosal flaps, and you can see they're pink. Even though I may have been drilling for an hour or so, they are pink because they're vascularized. They've got the septal branch of the anterior ethmoidal artery serving that mucosa. So it's a pedicle flap. And then you can move that around to cover the drilled aspect of the frontal sinus floor that you have drilled away. So it's actually got mucosal covering. Here I can see that I've got excessive degree of mucosa and I haven't got adequate cover laterally. So I will remove that and play it as a free flap, but I will only do it at the end of the procedure. So this has not been devascularized by sitting on the table or the surgical table. It's been vascularized throughout the procedure whilst I'm doing this procedure. So I'm trying to get circumferential cover for this natural ostium to be sure, not natural, but new ostium, to be sure that I've gotten. So a 0-degree scope, I can now look and I can preserve all of that mucosa. So preservation is the key thing in Draf 2B. Clear landmarks here with image navigation. It's the case with an osteoma, but this is the flap being raised. Now you will see that, which is the first sign you will see when you're raising your flap, which is the artery, which is running in the roof of the nasal cavity. That's not your first penetration. As you can see on the navigation, that is actually at the starting point, not the back end of your dimension. So you need to dissect this further back. So this is the groove being made, and you follow this artery all the way back till you get to the point of the 3 penetrations that you can see, 1, 2, and 3. And that's your point where you're certain where you are now at the posterior end of your landmark. This is where the skull base starts, and you can see the red mark on the sagittal cut, which shows you that that is my posterior most landmark. If I follow that, identify this, and I stay in front of this, then I'm always in the right place. What you can also see is that once I found that, on my right now through a transnasal corridor, as I enter directly into the frontal recess. I bypass everything below me and I enter directly into the frontal recess and get into the frontal sinus at this point. Allows me to then get over to the opposite side, drill the osteoma out, and then you can use different types of flap here. You can use a double flap where you have complex anatomy and you need to ensure that you need to be draining everything. And then flaps are the key things that you're going to do in frontal sinus. And I want to just talk for 2 minutes on this. they fall into different categories. Free mucosal graft. You saw how I had a pedicle component, and I took a component of that pedicle and used it as a free graft, and they work equally well as rotational flaps. You can get that either from the septum, the lateral nasal cavity, the floor of the nasal cavity, which is a good source because it's quite thin and it regrows very quickly there. Turbinate mucosa can often be a bit thick, which as can some of the septal mucosa. So my preferred sites are lateral nasal cavity or the floor of the nasal cavity as free grafts. The random pattern flap is one that I will describe in a minute, which is a laterally based flap based on a random pattern of vasculature coming from over the lacrimal bone coming medially. And then you have the vascularized posterior nasoseptal turbinate flap, which I just shown you on the image. So these are your flaps and grafts. So you can take this window that you would normally make, you can harvest that mucosa and then make your window before your draft 3, and you can keep that mucosa. That would be a free mucosal graft. The lateral base graft is on a pedicle that comes from the lacrimal bone over the roof of the nasal cavity and to a variable degree to over the septum. Now you can harvest all of this pedicled on a wide pedicle based over the lacrimal bone at this point, and you can harvest it and put that into the maxillary antrum, and then at the end you can redrape the lateral wall and the anterior wall using that graft. And the pedicle flap that I just showed you, which is based on the penetration from the septal branch of the anterior ethmoidal artery that comes to the skull base at this point, can harvest both septal and lateral wall in one limb. And you can tuck that away between the middle turbinate to be able to use that later, as I showed you before. So the key aspects, I think, is mucosal preservation, a systematic approach to this. I hope I've given you some tips about how I do my surgery that may be beneficial, and shared with you what I feel are the key factors in getting good long-term outcomes. Mucosal preservation, mucosal flaps, and a thorough procedure. If you just make a small hole and you put a drill in there, it will close down. If you're going to put a drill in there, you need to take the whole of the floor of the frontal sinus out all the way to the anterior wall, and then put your mucosal flaps in. And that's, in my opinion, how we get success. So once again, Christopher, I'd just like to say thank you very much. And I would like to invite everybody to the Frontal Sinus Course. We don't know whether it'll happen in January next year, but we have a very mixed faculty, American colleagues, as well as European experts, and then a British, and we have people who do things different ways. So this is very much for people who want to learn to do the same procedure in 2 or 3 different ways, because all of us have a different way of doing this operation, and we bring them all together for you at this course. So thank you very much.
Thank you very much, Anshul. It's amazing talk. Yeah, okay. It's amazing talk, amazing surgeries. I love it. Thank you very much. And as you said, it's good to have all views how different people approaches frontal sinus, because if you don't learn every single technique, you won't be able to treat all your patients. So even if you're prepared to do one technique, sometimes I have to change to another one because of anatomy problems or whatever. So it's really amazing. So one question I wanted to do to you is, you always put flaps in every case of draft procedure, or
draft 2B or 3, almost always, unless I'm dealing with malignant disease where I haven't got readily available graft. In that case, I will tend to go to the floor of the nasal cavity and try and harvest everything from below the inferior turbinate laterally to the midline as much as I can, and use that as a free graft.
Okay, perfect. And when would you use the frontal osteoblastic flap? In which case?
So grade 3-4 osteomas, neoplastic disease of the frontal sinus. I think neoplastic as in cancerous disease of the frontal sinus. You have to, anatomy, you got to get really good access to be able to achieve that. And if I've got more than 50% obliteration of the frontal sinus due to new osteogenesis, I prefer to come from above and from below and do a very radical procedure. Those are my three major indications for an osteoplastic flap.
Okay, perfect. I think all the audience is a little bit shy. I don't have any questions.
Okay.
But I want to continue the question regarding how you approach lateral mucosals.
Okay.
Because for me, at least, I know I can reach all the mucosal from the nose endoscopically, but the after month results, it's a little bit tricky. So
yeah. So I think lateral mucosals, I would prefer to use a unilateral. So as far as I can, I prefer to use a unilateral approach, because when you start creating septal windows and you alter the anatomy of the nasal cavity, you change the functionality and the physiology of the nose. And yes, you can manage it with douching, and yes, after a year or things tend to stabilize, but you do change the whole physiological way the nose works. So as much as I can keep unilateral procedures, I will. So my preferred approach would be a Draf 2B, and whether I can successfully do it with a Draf 2B will depend on how much of an anteroposterior lateral medial dimension I can see on my scans. If I see a very narrow lateral medial and anteroposterior, then I will go for a Draf 3 and allow me to approach with instruments from the opposite nasal cavity to be able to get laterally, to be able to take the medial wall of the mucosal off and try and preserve as much of mucosa, or use flaps to cover up anything that I drill up. So lateral, I always started off, when I started off, lateral ones I always did with the 3, but more I have started using angled instruments, which we have really nice ones now, together with scopes, angled scopes with 30, 45 degree scopes, allows us to really work from one side quite adequately. I then put flaps in.
perfect.
So my key thing is I found my revision rate has dropped significantly with the use of flaps.
But you have to use a really wide flap, no, to go laterally. You use
I don't put the flap. So it's rare occasions that I will put the flap into the mucosal.
Ah, okay, I understand. Yeah.
So I would, and I have a couple of examples if you want to see those. I've got a few examples which I haven't just saved up, but there are certain situations where, so for instance, if I had a mucosal laterally, as I showed, with most of the tract has osteoneogenesis,
yes,
you're going to drill that. Once you've drilled that, you're going to have problems with synechial closure. At that point, I would take a large flap and rotate it into the mucosal, and I call that fistulation. So it's actually creating a mucosal tract, and yes, it may not look beautiful, but as long as that mucosal drains, that patient's problem is it's fine, it's gone. And I also use that technique with some craniopharyngiomas. So sometimes, especially children, 5-year-old, 10-year-old, they recur quite often, and they're predominantly cystic. And if you take a Haddad flap and actually create and cover more than 50 to 60% of the circumference of your opening into your cranium, it will actually constantly drain. So the cystic component does not reaccumulate. And we published a paper on that, which is so I use the same concept to fistulate some complex lateral mucosals.
Yeah, I really like that concept. Actually, Philippe Hanman told me that he used it for Petrus apex granuloma, so I've been using it for that. It works amazing. It's really good. Dr. Ramon Moreno from Seville is asking if you use or you have experience with Propel stent. I think he's been.
No, I have no use. I have no experience with it. I've seen the literature and I've spoken to some of the people, and they're great advocates for it. And I think there is no doubt that if you've got some way of having local anti-inflammatory medication, it's going to be good for your long-term results. I have no experience of it. I do, however, use different ways of doing it. So sometimes I will use dissolving packing, such as nasopore, and I would put it into the area that I want to specifically address. And I would put something like Kenalog or some form of steroid on it that's going to stay there some time. And I would use such techniques to try and open up the frontal sinus if I have concerns about mucosal disease narrowing my natural ostium. But I have no experience with using drug-eluting stents in the frontal sinus. I can see good reasons for it, but I have no experience with it.
Okay, thank you very much. So, Professor Sama, I think we are almost 1 hour of webinar. So people, I think it's very interesting, have been very interesting. Thank you very much for this excellent talk, for sharing your experience, and sharing all your tips and the way of that you approach frontal sinus. At least for me, I've learned a lot. So
you're very kind, Christopher.
Yeah, so it's amazing. Thank you very much.
My pleasure. Thank you very much for this invite, and hope to see you soon.
Yes.
It's been a long time. We need to have a beer together.
Exactly. With a good glass of wine and
absolutely.
Okay, I'm sure.
Okay.
See you, my friend.
Thank you very much.
Have a nice evening. Bye-bye.
Bye for now.